Was a patient, a female patient, 32 years old, with symptoms since 2012, with heaviness, pelvic pressure, increased daytime frequency 5 times a day, nocturia 3 times a day, urgency, dysuria, and dyspareunia. And she had negative culture, burning, sensation, and vulvodynia. What about the physical evaluation? No anatomical defects. The allodynia on the great labia and fourchette. The vulvar Q-tip sensitivity testing with 2 cross. Multiple trigger points on the muscles. Strangely, mainly in the right side of the body. Cervical spine, hemidiaphragm, piriform muscle, levator, and internal obturator muscles. The suggested therapy was analgesics and myorelaxants, and as well as physiotherapy and biofeedback. Poor response. She was treated for some months, but without any particularly improvement. Then, because was suspected to have vulvodynia, they suggested to do Botox injection into the vestibulum of the vagina. Firstly, 50 units into the vestibulum, and then 100 units into the levator and internal obturator muscle, just to relieve the symptoms. Very, very, very poor response. And then she, other doctors, they prescribe antibiotics. They say, why? I don't know. But she referred to us antibiotics. Non-steroid anti-inflammatory drugs, amitriptyline and gabapentin to relieve the pain, and bladder instillation with cortisone. Some, I don't know why some other doctors. No response. The patient was referred to us, was very desperate, and we did a neurophysiologic evaluation of pelvic floor, and has been discovered a mild pudendal neuropathy, right side in the somatory sensory branch. I would like to tell you that this kind of exam could be useful, but in very, in our experience, in very little, because the pudendal neuropathy, what does it mean? Cannot change our clinical approach. Then again, after this neurophysiologic evaluation, has been proposed a physiotherapeutic approach with a temporary improvement, a postural approach, because considering that there was also some in the right side part, some pain, no effect, and also the psychotherapeutic approach. We performed urodynamics that was a very, very small capacity with the hypersensitive bladder, hypercontractility, and the cystoscopy demonstrated a trigon with pinpoint hemorrhages and bladder pain of the mucosa. We did 2 years ago bladder hydrodistension that revealed a severe form of inflammation with the bladder biopsy. They developed erosion into the urothelium, and the mast cell count was more than 30 for square millimeter in the detrusor muscle. We performed a substance has been called PEA to reduce the granulation mast cell with the improvement in the frequency to 8-10 times a day. We did also bladder instillation with hyaluronic acid and chondroitin once a week for 6 months. And finally, because was requested, because continued to have some kind, even though was a strong improvement, but the pressure and the contraction of the perineal body, 10 sessions of magnetotherapy and perineal rehabilitation with the reduction of VAS pain from 8.5 to 4.1. So, observation. First, could a psychological evaluation be helpful in the management of this patient? The answer is yes. Probably you need to prescribe also not only a physical or physiotherapeutic or clinical approach, but also a psychological approach. And a patient with chronic pelvic pain, pelvic floor hypertension, with poor response with a traditional therapy, think a bladder as possible source of a problem. This is very important for you. This is a strong message. And so, in conclusion, facing with the patient with hypertonic pelvic floor dysfunction and chronic pelvic pain due to bladder pain syndrome, you need to approach the patient in a multidisciplinary approach. Thank you.